A 71-year-old woman is brought to the emergency department by her daughter because of fatigue, dizziness, and palpitations. For the past few months, her diet has consisted of small quantities of coffee, rice crackers, and jelly. Laboratory studies show hemoglobin of 10.9 grams per deciliter, mean corpuscular volume of 105.9 FL, elevated homocysteine, and a normal methylmalonic acid. A defect in which mechanism characterizes the most likely diagnosis in this patient. So go ahead and pause this video and try this question yourself before we go into the solution. So to understand this vignette, it's important that we understand the metabolism of homocysteine. Homocysteine can either be converted into cysteine or methionine through a series of enzymatic reactions. For the purpose of this vignette, we're actually going to look at the conversion of homocysteine into methionine. A series of enzymatic reactions are coupled to this conversion, such as the enzyme methionine synthase. Methionine synthase requires the cofactor cobalamin or vitamin B12, as indicated by this green circle. This enzymatic reaction is also coupled to the conversion of tetrahydrofolate, which requires folate as a cofactor, into 5-methyl tetrahydrofolate. So there's an addition of a methyl group at the 5 region of tetrahydrofolate. Additionally, methionine will combine with pyrimidines and lipids to create propionyl-CoA, which will be converted into methylmalonyl-CoA, and the enzyme that does this is propionyl-CoA carboxylase. Methylmalonyl-CoA will then be converted into succinyl-CoA via the enzyme methylmalonyl-CoA mutase, and this also requires vitamin B12 as a cofactor. So, in patients who have a vitamin B12 deficiency, they will have an elevation of both homocysteine, because homocysteine cannot be converted into methionine without vitamin B12, and they will also have an elevation of methylmalonyl-CoA. However, if a patient were to only have a deficiency in folate or vitamin B9, then they would only have an elevation in homocysteine, and they would have normal methylmalonic acid levels. And the reason why is because homocysteine requires folate as a cofactor in this reaction that is coupled to methionine synthase, whereas the conversion of methylmalonyl-CoA does not require folate for the deficiency. So this is going to be the way you distinguish between B12 and folate deficiency, is whether or not the methylmalonyl-CoA level is elevated. So if the methylmalonyl-CoA level is elevated, methylmalonic acid, then in addition to homocysteine, then you're going to be able to determine that this is a B12 deficiency. Whereas if methylmalonyl-CoA levels are normal and homocysteine levels are elevated, then you can deduce that there is a folate deficiency, assuming that there is megaloblastic anemia. Now that we understand the metabolism of homocysteine, let's go back to the question. This elderly lady has fatigue, dizziness, and palpitations. So that's characteristic of anemia. And anemia is defined as a hemoglobin in females of less than 12.5 for females and less than 13.5 for males. We know that this patient has a hemoglobin of 10.9 grams per deciliter, which suggests that she is anemic. Additionally, we are also told that this patient has a mean corpuscular volume of 105.9, which is greater than 100 and suggests it's a macrocytic anemia. The two most common causes of macrocytic anemia is going to be folate and B12 deficiency. Folate is also known as B9. And the way that you determine the difference between the two is you look at whether or not there is elevated homocysteine and methylmalonic acid in B12 deficiency, or if there is just elevated homocysteine levels. In that case, that would be suggestive of a folate deficiency. So the fact that methylmalonic acid levels are normal, but homocysteine levels are elevated, can tell us safely that this patient has a folate deficiency. And this is consistent with their history of having a very poor diet of just coffee, rice crackers, and jelly. The body has a large amount of stored B12, and it would take a very long time to run out of B12 through dietary, through a poor diet, whereas the folate reserves are not as large. So if a patient is not taking a sufficient amount of green leafy vegetables or even folate fortified foods, then a folate deficiency can be seen in people with very poor diets, such as alcoholics on the street. So now that we understand this is a problem with a folate deficiency, since folate is involved in the transfer of methyl group at the 5' region to tetrahydrofolate, we can say that F, transfer of the methyl group, is the correct answer. Now that we know what the correct answer is, let's go through the rest of the answer choices and figure out why they are incorrect. A, glutathione synthesis. So this is a very interesting point in the sense that glutathione is very important in ensuring that there is no oxidative damage done to our tissues, but this would not explain a macrocytic anemia. So we can cross out A. B, heme synthesis. So the synthesis of heme requires the cofactor requires the addition of iron, and in the final step where protoporphyrin is converted into heme via the enzyme ferrocletase. However, the reason why this is incorrect is because iron deficiency is a microcytic anemia, and we have a macrocytic anemia here. Isomerization of methylmalonyl-CoA. So if we remember, the isomerization of methylmalonyl-CoA into the Krebs cycle requires vitamin B12, and this patient does not have a vitamin B12 deficiency. So even though they have a macrocytic anemia, this is not the correct answer. Synthesis of beta globin chains. So synthesis of beta globin chains, this is referring to beta thalassemias. And beta thalassemias are a type of microcytic anemia. So they would have a mean corpuscular volume of less than 80. Synthesis of spectrin actin cytoskeleton. This is referring to hereditary spherocytosis, which is a type of normocytic anemia. And in this type of anemia, you would see Howell Jewell bodies. So by process of elimination, F has to be the correct answer, the transfer of methyl groups.